Good morning, everybody. I'm Aaron Klein, and along with Prasanna Krishnasamy, we want to welcome you to the Oregon Bioethics and Humanities Colloquium today. We're really pleased to get to welcome Josephine Ensign, who is a professor of nursing at the University of Washington in Seattle. She teaches public health, health policy, and health humanities. She's been a nurse for over 40 years and has lived experience with homelessness as a young adult. Her scholarship and practice as a nurse practitioner focus on trauma-informed care and health inequities for people marginalized by poverty and homelessness. Ensign is the author of 4 narrative nonfiction books on homelessness. Skid Row, On the Frontier of Health and Homelessness, Is an American City, was a finalist for the 2022 Washington State Book Award. Her latest book is Way Home, Journeys Through Homelessness, which she may not plug this, but I will plug this. It is a really interesting and heart-wrenching read. So with that, we're really pleased to welcome you, Dr. Ensign.
Thank you, Aaron, for that introduction, and thanks everyone who's joining us this morning. So I can go to the first slide, please, Dave. So what I want to talk about today, this, by the way, those of you that are familiar with the Seattle area, I took this photograph the summer of 2017, 2018, I think it was 2017, when I was teaching a health humanities course at Harborview Medical Center here in Seattle. And they were in the process of tearing down Yesler Terrace, which was our country's first racially integrated public housing. We have mixed housing that is in high rises that are up instead of that. So just again, as a juxtaposition showing health and homelessness, or not having adequate affordable housing. So next. So what I want to do today is highlight homelessness, health needs and concerns. I know a lot of you already work in this area, so that we'll be hopefully adding on to what you already know and have as experiences. I'll bring in and weave in case studies and examples from my work and share resources and best practices. Next, please. So this is a young me and a more recent me. I began this work in my then hometown of Richmond, Virginia. And this was in the early to mid 80s when we had across the nation had a massive increase in what we now, looking back, refer to as new homelessness. I'm washing the feet of one of my patients. I ran an early rendition of a healthcare for the homeless clinic, which is now called Daily Planet, still running in Richmond, Virginia. And this client is a returning Vietnam vet. And I really love doing foot care and also teaching our students, our medical and nursing students, proper foot care for people experiencing homelessness. Super important for people who are, schlepping around heavy backpacks, having to walk between services, and also, as kind of shown on the left-hand side, there I am in pink, and we're doing foot care clinics at some of our Seattle area shelters, and that's with some medical students. And I also love doing this. I still do this with our medical and nursing students, especially at a women's shelter here in the University District of Seattle, because it also teaches humility. Or I don't think you can teach humility, but it reinforces humility, where actually even physically students are below the patients or the guests or the clients. And so I think it's an important part of it. Next, please. So these are some of my books. I have felt, started in 2016 when I published what I call my medical memoir, which is my own story of working as a nurse and a nurse practitioner, providing healthcare to people experiencing homelessness in Richmond, Virginia, and then my own kind of spiral into and back out of homelessness as a young adult. And Skid Row tells the story more of a historical, like looking at the roots of homelessness here in Seattle and King County and in the Pacific Northwest, tracing all the way back to our first official homeless person or indigent pauper that King County took care of back in the early days of the settler colonial city, and kind of how the reverberations of a lot of those historical seeds, and including like our poor laws and how they developed, who's worthy and who's an unworthy poor, which of course are still very much alive today, how those really impact our communities and our healthcare provision. Next. And yes, thanks for that little plug about Way Home, Journeys Through Homelessness. This did just come out from Johns Hopkins University Press. And it is a book that I researched and wrote during the pandemic. And so it really focuses on what I call policy narratives. So it's stories of people who lived, during this time period and before experiencing homelessness, too often who died, including at police hands, and also has more uplifting stories, I guess, of people who survived homelessness and not only survived it, but are thriving and are giving back to our communities and doing really amazing, innovative work. I get the great pleasure of working with a lot of them. So it's a lot of it's told through their stories, their voices. Next, please. Another one that I'd call your attention to, a bit of a labor of love, but I have enjoyed doing it for the past 10 years. I'm continuing this, but I've done so far a total of 63 oral history interviews with people living and working at the intersection of health and homelessness in Seattle and King County. And it includes people like Anitra Freeman, who I work with, who does, she helps to lead vehicle residency outreach here in Seattle that my nursing students have the honor of being able to learn from her and go with her and the other team members out on the road, but also people like Dr. Michael Kopus and others who've worked tirelessly in terms of provision of healthcare for people who otherwise, are shunned by our society. Next, please. And that one's available. The Skid Row podcast is available on Apple and also Spotify. And this one is a story map that has digital storytelling videos, kind of like short 5-minute videos that I tell sometimes through the stories of people who've experienced homelessness, and it includes the story of Edward Moore, Seattle's first homeless person. So that's available. These are all free of charge, no paywall. Next, please. The other thing that I love doing that is within kind of the realm of what I call health humanities is meaning of home exercise. It's a values clarification exercise that I do with people on, just what home, thinking about the word home, what it means to them. Realizing again that in too many cases, people have never had a safe place to call home, and that obviously really complicates our healthcare provision, as well as their kind of life trajectories and feeling safe in housing that we might be able to offer them. What I do with them is they come up with a one word that is kind of like the most important to them, and then they write an American sentence, which is Americanized haiku. And so the one In the purple, My Bulldog, My Protector, Chased Away the Pain, Comfort in the Rain, was by Todd, who was a member of Tent City 3, which is one of our sanctioned tent encampments, long-running consumer-led tent encampments here in Seattle. Next, please. And these are from a workshop, charrette, that I helped facilitate here in the University District, and this was with homeless teens and young adults. And so I'll read just a couple of them for you. Again, meaning of home exercise, an American sentence. Where you shed your travel pack, where you wash your socks and underwear. Okay, next, please. And this one is always a crowd pleaser. The one in the middle, Tuna came one day, scratched at our door, begged for food, and never went away. Home is where the cat is. And there's a drawing of Tuna for us as well. And this is also from a resident of Tent City 3. And I've done these workshops in many different settings. I am a speaker for Washington, Humanities Washington, and have gone around and done homelessness and the meaning of home workshops throughout Washington state. I'm going into my second year, including in like tiny little places in Eastern Washington, which are very politically conservative, but pretty much everywhere. It's not just an urban issue in terms of homelessness, are grappling with homelessness in their midst, and compassion and misinformation, and what to do about homelessness. Okay, next, please. So just some homelessness definitions briefly, or terminology. So I do use homelessness. I recognize that a lot of advocates really prefer to use houselessness to focus on the fact that, yes, homelessness is basically about not having a house. But from my perspective, it's not just that. It's not just having a safe, affordable place to live, like a roof over your head traditionally, but it's also those meaningful affiliations, whether it's family or found family, or friends, and community cohesion that makes it a home. And then also, obviously, people first language of people experiencing homelessness. Okay, next, please. And this one, this one I want to just point out of how complex official definitions are of homelessness. For a long time, we didn't even have a unified federal definition of homelessness. And next, please. And a reminder that health and homelessness is kind of chicken and the egg, that poor health and trauma, especially untreated, undiagnosed and untreated PTSD and childhood traumas, can cause and contribute to homelessness at an individual level. These are within systemic, larger systemic issues of all of the different isms: racism, ableism, and socioeconomic kinds of things. Homelessness complicates healthcare treatment and recovery process. A very valid distrust of the healthcare system for a lot of people. They haven't always been treated very well within our healthcare system. A lot of times, unfortunately, they rely on emergency departments for some of their care, and if they don't have access to good, accessible, and culturally relevant primary care. And poor health and trauma prolong homelessness. It goes into what we kind of term now chronic homelessness. Next, please. And social exclusion is a term and a concept mostly growing out of work in the UK and Europe, and refers to individuals, groups, communities stigmatized and having intersectionalities. So groups that are identified as being a kind of extreme social exclusion. One of the main ones are people experiencing homelessness, migrants, refugees, sex workers, Roma. which is a term they still use in the UK. Travelers, we use more here. Incarcerated people with mental illness and substance use disorders. And some of the, I just want to point out here that some of the pushback against using kind of social exclusion and the flip side of that of inclusion healthcare is the ongoing debate about whether focusing on certain populations or subpopulations of people who are have extreme social exclusion, whether that doesn't inadvertently kind of perpetuate stigma for people that are experiencing these situations. Okay, next, please. And the UN definition of social inclusion. And here I just want to emphasize that that all of this really not only encourages, but pretty much demands participation by citizens, by patients in the decision-making processes that affect their lives, including within healthcare, and of how to do that in a meaningful and respectful way. Next, please. So different dimensions of social inclusion, obviously health and access to services is one of the kind of like main dimensions besides just economic participation, education, interacting with society, fulfilling social roles, and kind of self-determination, which is hugely important and oftentimes too overlooked in our work with people experiencing homelessness. Okay, next, please. No, a lot of you are already familiar with this. Those of you that are in the Portland area, that you have experienced, especially since the pandemic, the decriminalization of substance use, and then kind of the pushback on that and the recriminalization. Here in Seattle, we have experienced similar kinds of whiplash, really, and we're also, as of October, unfortunately, having an increase in criminalization of homelessness, not just in terms of a massive increase under our current mayor and city council of encampment sweeps, but also bringing back some very antiquated and proven to be unjust and also not cost-effective laws of the stay out of drug areas and stay out areas of prostitution, which is massively impacting in a negative way our clients, our patients, but also like even the services of where we can provide them. So to remember that the criminalization of homelessness and of poverty, of just what that does to people, what that does to us as a society. One of the workshops I did this last year was at Coyote Ridge Correctional Facility with about 50 men who are incarcerated, and they get this big time, just in terms of like where they came from, into prison, what they were dealing with before they came to prison, and facing dire circumstances when they are released, and that increases recidivism, and then also having the criminal history really is a barrier to housing and other kinds of instabilities. Next, please. So inclusion health, in this I've done some work in the UK with a group, NGO, nonprofit group called Pathways, and they work alongside the NHS on inclusion health and focusing specifically on people experiencing homelessness, but also all of the other groups that are identified in terms of having extreme social exclusion. They include outreach workers. We in our country usually say people with lived experience of homelessness, and they call people who work on their teams and even work in outreach to hospitals with discharge planning, experts by experience. Next, please. Next, please. Thank you. This one, socially excluded populations are having extreme mortality excess mortality rates. And so this is from a meta-analysis that was done nationally, and this is in the Lancet back in 2018. And disproportionately especially for women. Next, please. I'll show you some local statistics. And this is looking at deaths of people who are homeless in the US since 2016. And this was published in The Guardian in 2022. Next, please. And coming down here, this is Matthew Matfow. I had the pleasure of working with when he was doing his initial research, and finishing his doctorate here at University of Washington. And he's done a study looking at 20 cities across the US from 2011 to 2020, and what he calls mortal systemic exclusion and steep mortality rate increases. I'll show you some of the statistics in the next slides. So next, please. And that one was published in Health Affairs. So this is showing the number of homeless people who died and rates of homeless mortality for 22 localities in 10 US states and Washington, D.C., and showing a steep increase. And this, was just at the beginning of the COVID-19 pandemic. It increased even more, unfortunately, during the pandemic, as it did, for the overall even house population. Next, please. And the top 6 homeless mortality rates by cause for the 22 localities in the 10 US states and Washington, D.C., overwhelmingly overdose, drug and alcohol, and also cardiovascular, traffic injuries, homicide, and suicide. Next, please. So this King County, the coroner's medical examiner's office, since 2003 has started to collect data on not just overall mortality for people who come to, who die, who come to the medical examiner's office, and for cause of death, etc. And they have also broken it out by where people live, like where they died. So including for homeless deaths. And this shows for the overall population and drugs and poisons. And the other one, which I didn't include the slide in this one, but for, and this is current as of early this month, that we so far have had 309 deaths through the coroner's office and medical examiner's office who have died while living outdoors or homeless, and overwhelmingly from drugs and poisons, as well as cardiovascular diseases. And the good news is, which hopefully you're also seeing in the Portland area, we're starting to see a decrease in deaths from overdose for not just people experiencing homelessness, but also for a general population. Concerted efforts across the health department, hospitals, and others in terms of real harm reduction, having easy access to medications, etc. That has decreased the number of deaths so far. Okay, next, please. So this is for Multnomah County. You have a similar kind of review of deaths among people experiencing homelessness. And this is the most up-to-date ones that I could find. I think it gets published in December, so it's probably coming out, at least for 2023, pretty soon. Next, please. And looking at mortality risk comparisons to the general population. So like transportation deaths, being hit by cars, pedestrian safety for anybody, but then especially for people experiencing homelessness is huge, and then drug overdoses. But even again, for excess deaths from COVID-19. Next, please. So these are resources that I would point out to you. I would recommend that you watch and read. The first one is a video. I think it's about, it's less than half an hour long, and it was put out by the NHS and Pathway, the inclusion health group that I told you about earlier that I've worked with. And it's really excellent in terms of, even in a country like the UK, of having, it's not perfect, no country is perfect, of having at least a health program like the NHS, that the difficulties of people accessing good health care. So, and it's told through the stories and words of people who have experienced this. And then the other one, really excellent, kind of long form reporting, State of Mind, Denise's Last Days, and is talking about the story of Denise and her struggles, end of life kinds of things, while also experiencing homelessness, and all of the different kind of barriers, and also programs that helped her to have hopefully a more dignified death. Okay, next, please. And any kind of talk about homelessness, I have to always remind us all that homelessness is not an equal opportunity affair, that yes, different kinds of circumstances, especially increase in sorry, somebody was dinging me, I had to turn them off. Increase in natural disasters are causing temporary and long-term homelessness for more people, but it really is disproportionately falling on people of color. In Seattle, and that's the photograph here, is from Pioneer Square, some art, public art, and reminding us that that Indigenous community members are the most disproportionately affected by homelessness, whereas the overall population of Seattle who identifies as Indigenous is 1%. 19% of people experiencing homelessness are identify as Indigenous, and 32% of people experiencing chronic homelessness are Indigenous. Next, please. And this, I got permission from the men sitting here. This is near Pike Place Market in Seattle, and this is public art and a program, the Homeless Remembrance Project, which I really love and support. A group of women who experience homelessness got together, women in Black, probably about 20 years ago, and we're pushing back against especially news reports of people who had died while homeless that were very demeaning to them, and not treating them as people and as loved friends and family members. So they started this project. This is the Tree of Life, and the little cutouts under where the pigeons are standing or sitting, whatever they're doing, are bronze leaves of remembrance. And the other thing to say about this is it's a long time meeting place for people, Indigenous folks, urban Indians who are experiencing homelessness, as these men here were doing that day. And one of the stories that I write about in my newest book is about the unfortunate and really avoidable police killing of a longtime wood carver who's Indigenous, was Indigenous here in Seattle. Okay, next, please. And this is bronze leaf of remembrance that is embedded in the sidewalk. They're embedded in the sidewalks all around Seattle. If any friend, caseworker, family member wants to remember a person who has died while homeless, they can, for free of charge, get this leaf of remembrance and have it placed with a little ecumenical service in a place that was meaningful to the person who died. And so this one is for Lisa Bach, who unfortunately spiraled for the first time into homelessness during the COVID pandemic and died by intimate partner violence in a tent encampment in a park in central Seattle. Next, please. So this, I won't belabor it. I want to give time for it. I saw some questions. So again, to remember that traumatic experiences are events that actually involve threatened death or severe injury. And for those of us working in healthcare or social care, of also recognizing that learning about these events who occurred to close family members or friends, and then also the vicarious trauma that can happen to us in the helping professions as we're trying to sit with people, walk with them, and hopefully help them to survive and overcome traumas. Next, please. Complex traumas, repeated prolonged trauma, that's interpersonal, primary caregivers, and at developmentally vulnerable times, childhood, adolescence, severe illness, disability, and old age. And this I see a lot among people who I've worked with over the years, young people to older people and everything in between, who have had, again, unrecognized, untreated complex trauma, a lot of times from childhood, and how that really complicates any kind of service provision, accepting different kinds of housing options or healthcare options, and that we have to recognize those and try to get people help. The other thing I always remind us, all, including myself, is that traumas, even complex traumas, can be treated, can be overcome, and with enough assistance that is appropriate to the person. Next, please. So this trauma-informed care, I know a lot of you have already had this in different trainings or your education. It's interesting just to think back historically, trauma-informed care really grew out of both the VA, and trying to start to recognize and treat PTSD among veterans, but also healthcare for the homeless. And the one at the bottom is, the bottom two are really important to support hope that recovery is possible, and to support staff and implement ongoing burnout prevention best practices. Next, please. The trauma and homelessness, again, I mentioned this on an earlier slide, but it also often contributes to homelessness, especially for teens, young adults, women or female identified folks, LGBTQ folks, and also people that are living with domestic violence and intimate partner violence. That homelessness itself is a risk factor for more trauma, really vulnerable people out on our streets who are preyed upon. And this one is substantiated by a growing body of research. Homelessness is a deeper trauma than active combat for U.S. veterans, which I think is very, very powerful statement and truth. And significant trauma before and during homelessness complicates our healthcare, social support services, and education. And then again, remembering the role of historical trauma, especially for persons of color, for our Indigenous community members, and then sanctuary trauma. And sanctuary trauma, I think, is an important term that isn't known enough, but that is trauma that happens when we're trying to provide sanctuary, we're trying to provide the best healthcare, social services, and inadvertently we're actually perpetuating trauma. Next, please. So effective healthcare services, sensitive to patients' very well-founded fears of authority figures and systems. So that's, again, why kind of having ongoing primary care for people, having ongoing outreach to places where people go, like the women's shelter where I work, to kind of build up trusting relationships. We have an excellent health navigator now who works at the women's shelter, female identified shelter that I work at, who can walk alongside people, can help them even not just make appointments, but go with them to services. And services that address developmental and educational issues, services respectful of patients' unique subculture, street families, alternative economies, protection of identity, using street names when possible, besides preferred pronouns, and also services that are respectful of patients' knowledge and survival skills. And I can say from personal experience, and then also hearing and witnessing stories of many people who've survived homelessness, that it takes a lot to survive homelessness, and then services that apply trauma-informed care. And the one thing I wanted to point out here, what we're seeing, and I'm sure I know a lot of people around the country are also seeing this, as a sharp increase in the number of elderly people who are experiencing homelessness for the first time. We're seeing a massive increase in the number of older women who are, living in shelters, living on the streets. And one of the really complex kinds of paths with them is not only, the usual kinds of suspects of what they might be dealing with in terms of behavioral health issues, but also, what comes on, both physical aging kinds of things as well as dementia, and how to navigate those waters, including with adult protective services, can be very frustrating and heartbreaking. Now, I recently had treated an 80-year-old African-American woman experiencing kind of chronic homelessness. And our nursing students, over time and working with her, where she finally let them take a look at her feet, and her toenails were about 3 inches long, and probably seen these sometime in your career where they're curled around and starting to dig into her feet. She'd been walking with a limp for as long as a lot of the service providers who worked with her long-term could remember. And we worked for a fairly long time and were able to cut her toenails. She was able to then walk without a limp. Unfortunately, she's beginning, and she's like the sweetest, most docile person baseline, but she's beginning to have dementia-related personality changes, and she got angry at women's shelter staff, and she's banned for 3 months during the coldest months of the year here in Seattle. So their staff are trying to work with adult protective services to get her more permanent supportive housing. Oh, and next. So evidence-based interventions, a lot of pushback, especially now in our current political climate, ongoing political climate, against housing first, but we do know that it is evidence-based. It's not perfect. We do need more housing first options that are like specifically for instance, the elderly population, also for folks who are in recovery and want to be in a sober housing first, and peer outreach or experts by experience, community public health, physician outreach teams, street medicine types of programs, and harm reduction, which again is getting massive pushback that we have to watch out for and try to protect. And next, please. So the good news, is that we do know how to reduce and end homelessness. It's just that we don't have an ongoing political will to do that. Statistics report that just came out this year for Washington State called Yes to Yes, Washington State Unaccompanied Youth and Young Adult Homelessness. And this is over 8 years, had a 40% reduction in youth homelessness. And this, the years span the pandemic, and it was concerted effort. We have an Office of Homeless Youth that started right before this study began, and a lot of different really innovative programs throughout the state who are working with communities, including smaller communities like Yakima, to support kind of good enough families to keep young people in their communities, and to prevent homelessness and to quickly rehouse people. So we know we can do that for homeless youth. Whether we can kind of sustain the funding and everything needed for that is another question. And then the other big win that we've had as a nation is a really significant reduction in veteran homelessness after the implementation of Ending Veteran Homelessness Initiative. And a number of studies, including the one that I'm showing here, that have come out. This one is showing a 55.3% decrease in homelessness among veterans, compared with an 8.6% decrease for the general population over the same time. And this is continuing to reduce, and showing how kind of a unified health system like the VA is, the closest that we have to socialized medicine, I always remind people, can really work. I mean, that, combined with housing and social supports. And next, we're at the end. I can I guess just point out the one that's underlined here is moral distress service rationing that goes with burnout a lot for those of us working in this field. And that's, again, going to increase with the incoming administration. Next, please. Some resources for Housing First. And you can just scroll through the next slides because they're resources. And these will be made, I will point out, or wait, if you can go back one. I just want to call out Oregon has trauma-informed Oregon resources, which are really excellent. I think it's through the state and also through the health department of organizations looking on trauma-informed care resources. Next, please. Others, and next. And National Healthcare for the Homeless Council, if you don't know that, Clinicians Network. If you don't know about that already, it's excellent. It has free resources for clinicians, as well as people experiencing homelessness. I'm on their policy committee. Next, please. And other resources. So are there questions that people have? I think I saw fleetingly a question, but it flew past me.
Thank you, Professor Ensign. Yeah, I think so. I would encourage people to either type questions into the chat or unmute and share your question with the group. Yeah, the question. Maybe I can just summarize the question that's in the chat from Nirmal Ladar is it was sort of a two-part question. One that you already sort of answered, which was how does what's the intersection between older age and homelessness, and you sort of spoke to that with particularly among women who are older age. But the second question was about how common mental illness is in this population, and I guess I would add to that, what is how do you understand the sort of intersection between substance use and mental illness in homelessness?
Yes, so that that gets to it's a really good question. It's one that lots of people ask, not just within healthcare, and that is to remember that visible homelessness that we have in our cities, in our kind of even our rural areas, that that is most likely going to be people who are chronically homeless, and that by definition have kind of accumulated, life traumas that have contributed to mental illness and substance use disorders. And to remember that just the state of homelessness, and that's why I do the meaning of home exercise, is just how disorienting not having a home is for anybody. And that if there are pre-existing vulnerabilities for people who then fall into various forms of homelessness, that can exacerbate mental illness and also substance use disorder. And they might begin using, for instance, methamphetamine, kind of a functional use of it to stay awake at night, to be safe if they're out on the streets or living in their vehicles. And then that gets into, a real dependency that gets away from them. And also to remember, again, our country really likes to focus on individual characteristics and blaming people for their situations, and to kind of keep in mind these larger socioeconomic and structural kinds of factors, including racism, that go into contributions to homelessness in our country, and a lack of will for providing basic services like, primary health care, and also affordable housing, safe housing. Any others?
Well, maybe as people are gathering their thoughts, I had a question about. I mean, part of what you're doing is shining a light on this issue, and besides a lot of our exposure in the clinical world to individuals who are experiencing homelessness, the usual way we encounter this is through the media, and I'm wondering what you think about sort of the balance between invisibility, sensationalism from media versus invisibility, and particularly when we sort of, particularly as the media landscape itself sort of changes, and maybe reliance on sort of media ethics is maybe a more dicey proposition than maybe it would have been 10 or 20 years ago.
Yes, no, that's a really good question. It's one that I kind of ethical issues that I wrestled with myself, especially in researching and writing my Way Home book, because it's like it begins with the story of the murder-suicide of Lisa Bach and Travis Berge, and it was during the Chaz Chop protests that we had here in Seattle, at the beginning of the pandemic and the aftermath of the killing of George Floyd. And there are a lot of and especially Travis Berge was very much of a media. I mean, he loved the media, chronically homeless, spiraled in and out of hospitals, untreated behavioral health issues, and lots of different complications. And how I wrestle with the ethics of that, and how to write about that without feeding into the sensational media frenzy that had happened on an ongoing basis with him, and how to be respectful. For him, I didn't have a lot of sympathy for him. I have to admit, I had to struggle with that. I didn't know him personally, but especially for Lisa, who so many missed opportunities that we as a community, could have prevented what happened to her and even to Travis. So yeah, and like the Seattle Times, for instance, here, our kind of one remaining newspaper, has a project, Homelessness, where journalists specialize in writing stories about homelessness, and they go through, I know one of the journalists personally, so I know this, who've gone through a lot of ethics kind of training, how to, working with people even experiencing homelessness, of how to be respectful, how to write more meaningful articles that deal with the issues, but that also are respectful of people who are living homeless. There's kind of an erosion of that even here in Seattle currently, and definitely kind of nationally of, around the whole Supreme Court ruling this past summer of Grants Pass, and where like some media really did try to kind of go back behind the scenes and understand a little bit more in depth, but how a lot of it was just kind of sensationalizing it and not helping to move from my perspective, not helping to move the narrative along in a productive way, and not highlighting things that work, like, again, veteran homelessness, like in our state, teen and young adult homelessness. And by the way, one thing I wanted to add that people a lot of times don't recognize is that one of the biggest risk factors for adult, especially chronic homelessness, is childhood homelessness. And so in terms of just looking at prevention, if we can prevent, child, teen, young adult homelessness in the first place, that will go a long ways towards preventing chronic homelessness in our country. Again, it flashed before my eyes. What's this? Yes, this is from Jacqueline. So Rosehaven, looking at the female population. I know a little bit about it. I can't say that I know a lot. I have worked with people here in our veterans homeless outreach program, including some of the nurse practitioners who I've taught in the past, who really, was going back like 10, 12 years ago, were beginning to focus on like sexual abuse among female veterans, and how that contributed to and complicated homelessness, and looking at programs that were supporting women, and also trying to prevent that from happening on an ongoing basis. But that's as far as I know about that one. Any others?
There's another question in there from Susan Toll, who was the longtime director of the Center for Ethics here, who wanted to know if you have other suggestions for language and communication as we sort of move forward.
Yeah, that's a good question, man. There's going to be like so much pushback, right, on inclusive language at the federal level on down, as well as massive changes in Medicaid and other basic support structures that we all have to be aware of and somehow push back on. So that for me, it's using the language that people prefer, if at all possible. Again, I really like people first language. It's a little bit more cumbersome, right? But it is respectful of people and putting them as people instead of as a disability or as a situation like homelessness. One thing I would say, one of my recent interviews, again, I have it on my podcast, is with a woman who experienced chronic homelessness here in Seattle, who now is housed and is actually working on kind of regional homelessness issues. She says that she's moved from using people experiencing homelessness to people surviving homelessness, to really emphasize that the survival aspect of it, which for me, and then, as she was talking with me, includes the survival skills that people have to have, unfortunately, right? So like more strengths-based approach, but also the fact that this kind of shouldn't be happening in a civil society, in a country with so many resources like the US. So that's one thing that just comes to mind of recently where I've listened to her and started to also use people surviving homelessness.
There's also a question about how do you think cities should balance sort of economic interests with with the
Oh man,
with the needs of homeless individuals, and particularly as I guess there's attention to sort of the what is the the talk about the doom cycle in downtowns.
yeah, that's huge. I mean, that's a major contributor to why our current mayor and city council, which is very, very conservative now, reenacted the soda and soap laws. And my students had accelerated nursing students with me this fall in the women's shelter and going with the vehicle residency outreach team. And they did research on this, and they found kind of the contract between the city of Seattle and, is it FIFA? Yeah, we're going to have the World Cup series coming the summer of 2026. And there's specific, explicit language in there requiring the city to clean up homelessness and giving money to, the way the city's doing it is giving more money to outlying areas in King County outside of the city center, including shelters, because they're going to really just basically bust people out. The warning out that goes back to ancient Britain, the warning out system. And so that is contributing to a lot of turmoil. The whole even bringing back the soda and soap ones, apart from preparing for FIFA, of trying to revitalize downtown, reactivate. The other kind of language is reactivate our city parks, which you always have to ask, what does that mean? Who's in power? How are they trying to reactivate them? Who's going to get pushed out? So I would not want, and I never will be, a politician, because I know there are legitimate, business and money interests, et cetera, but I could not do that from a compassionate standpoint. But I know a lot of people, including here in Seattle, Healthcare for the Homeless, et cetera, who are trying to work to have pushback on some of that rhetoric and the negative fallout on the people that we care for. And the other thing is trying to look at it from a reasonable standpoint, the evidence base again, that we know from massive amounts of research, even on the soda and soap laws, they don't work. They don't work. Encampment sweeps don't work. They don't reduce the number of of unsheltered people. I mean, people have to go somewhere, and we don't have enough shelter and enough housing that is appropriate for them. We don't have enough, police. We had the whole defund the police thing, and then trying to refund the police, and so talking with people like in the general public about that, of this doesn't work to eliminate, homelessness. People have to go somewhere, and it also is not cost effective. There are other ways. Like even Healthcare for the Homeless now is talking about, they term it temporary supportive housing. So that's sanctioned encampments, whether it's RV vehicles or tents, with supportive programs and services, including like healthcare outreach. And of course, the Trump administration is really talking about having basically internment camps outside of cities, poor farms to send people who are homeless to, which is really obviously not effective and is draconian going way back.
So I want to be mindful of other people who have other commitments. But if there are further questions, Professor Ensign has agreed to sort of stay on and answer them. But I do want to take this opportunity to for everyone who has to go to thank you for a wonderful talk, and we're really grateful that you talked to us today. And I want to, before some people go, I want to say that our next speaker in this series is Chris Feutner from the Children's Hospital of Philadelphia, which I'm sorry, Doug Diekema. sorry from Seattle Children's.
Oh, good.
Who's going to talk to us in early January 10th.
Nice.
So thank you so much for
yes, thank you.
us today.
Appreciate it.